Hello and welcome to the Foundations of CAR-T. This is part of the BMT101 CTTC webinar series. I'm Kevin Hay. I'm a hematologist with the Leukemia Bone Marrow Transplant program in BC. So the objectives of our talk are to describe what CAR-T cell therapy is and identify currently approved clinical indications for CAR-T. Secondly, to diagnose and manage CAR-T related toxicities. And thirdly, to summarize the state of CAR-T in Canada and critically assess the challenges in the field. So what are CAR T cells and what is the T cell's role in cancer? Well, T cells really recognize cancer cells or virally infected cells through various different mechanisms, but when we're talking about cancer cells, it's typically that they recognize a neopeptide that's associated with that cancer that is presented through MHC presentation to the TCR receptor, and then the T cell gets activated, leading to release of perforin and granzyme, which kills the cancer cell, cytokine production, as well as T cell proliferation and survival to really make those T cell clones to grow out and to kill more of the cancer cells. Now, the TCR structure is complex, as you see there, involving multiple actors as well as co-stimulatory domains, as you see through CD28 and 4-1BB that are presented here. Now, what CAR T cell therapy does is it allows for T cell activation against a specific cell surface antigen that's independent of MHC presentation. So what we have here is that we've hijacked basically the CD3 zeta endodomain, which is the end signaling pathway through the TCR structure. We've latched onto it the co-stimulatory domains, such as something like CD28 or 4-1BB, and then through a transmembrane domain, we've linked it to some sort of antigen recognition domain. So what's commonly used is monoclonal antibodies, as you see here, and specifically those variable regions of the monoclonal antibodies that make a single chain variable fragment, or scFv, that then is now able to recognize the antigen on the surface of the tumor cell. Now, how do we make these CAR T cells? Well, we need to get this CAR gene, this chimeric antigen receptor, into the T cells. So we first harvest the T cells via leukapheresis procedure, as you see in 1 here. And then in 2, we introduce the CAR into the patient T cell using replication incompetent, usually lentivirus or retrovirus, that enables genomic integration of the CAR under the control of a promoter, which then allows for the CAR to be expressed on the surface of the T cell. We expand these in the lab in the presence of certain cytokines, and then the CAR T cells are administered back to the patient with immunosuppressive lymphodepleting chemotherapy, typically fludarabine or cyclophosphamide, to be given prior to the CAR T cells being administered, due to the fact that this helps the cells engraft in the body and helps prevent rejection of the transgene. So, and then after the cells engraft in the body, they expand, and over a period of time, typically within the first 2 weeks, and then subsequently contract a bit over the next couple of weeks, and hopefully enter a persistent state where these cells may last in the body for a longer period of time. So it's important to ensure that your patients know that CAR T is a genetically engineered cell therapy, which has become a living drug. So let's step a little back to the CAR structure itself. As you see, there are various different co-stimulatory domains that can be used. The 2 that are really furthest advanced in clinical testing are 4-1BB and CD28. Now, there is some thought that 4-1BB kind of leads to a longer persistent state, a more central memory, really drives it towards oxidative metabolism, whereas the CD28 is a very strong stimulation that occurs, leading to more of an effector phenotype of these CAR T cells, and leads it down a glycolytic pathway. So you tend to get expansion earlier on with a CD28 product compared to a 4-1BB product, and also there's higher rates of toxicity potentially with CD28 targets, But it's really unclear because there's no head-to-head trials if one approach is better than the other. And the other thing to know is that there are further co-stimulatory domains that are under development or different combinations. What we would call a third generation CAR T cell would include 2 co-stimulatory domains, for example. So the field is moving quite rapidly in this realm. So stay tuned. Well, what makes an ideal target for CAR T? Well, simplistically, it's something that's on all your cancer cells, and it's absent on non-cancer cells, or absence of the normal cells is tolerated and manageable. So that's why CD19 is such a good target for B-cell lymphomas and leukemia, because you can live without your B cells. If you need it, you can give somebody IVIG. And same thing with BCMA. We can live without our plasma cells with immunoglobulin support if needed. So I'll just run briefly over some major papers in CAR T cell therapy and focusing really on approved indications for CAR T cell at this point in time. So one of the major papers was this one by Maud et al. In New England Journal in 2018, which is the Atlanta trial, which was Tisasil in pediatric and young adult B-cell ALL, which was a 4-1BB co-stimulatory product. The FMC63 is that scFv domain that's used to recognize CD19. And you can see of 75 patients who underwent CAR T-cell infusion, they had a remission rate at 3 months of 81%, with a fairly good adverse event profile. The main things you note here are cytokine release and neurotoxicity, which I'll go over in more detail later. But essentially, this is the study that led to FDA as well as Health Canada approval for B-cell ALL for age 25 or less. In third-line non-Hodgkin's lymphoma, there have been a number of trials. These are the major products that are on the market currently. So axicabtagene cytolucil, tisagen lacolucil, lisocabtagene maraleucel, and brexacabtagene autoleucel. So Axicil here is really approved for in Health Canada, approved for diffuse large B-cell lymphoma, primary mediastinal B-cell lymphoma, or transformed from follicular. Tisasil is approved for DLBCL or transformed follicular. Lisocabtagene maraleucel is not yet Health Canada approved, but it is FDA approved, and we're expecting probably in 2024 or so that this will probably get Health Canada approval. The company has just delayed their plans to come to Canada for this. And then the Brexacil, the last one, this one is actually for mantle cell lymphoma currently and may become an indication in adult ALL. There's some slight differences. All of these have the same scFv that's the FMC63 that targets CD19. The Kite Gilead products, the Axicil and the Brexacil, have CD28 co-stimulatory domains. The Tisasil and Lysacil have 4-1BB co-stimulatory domains. The Lysacil product in its manufacturing has this final manufactured ratio of 1:1 for CD4 to CD8 T cells in its final CAR T cell product. The Brexacil is different than Axicil because they do a T cell selection step as opposed to using bulk PBMCs. Lymphodepleting and chemotherapy is relatively the same in comparison. The 4-1BB products you see here can be given as an outpatient, although the Axicil and Brexacil, they are trying to move towards trials to see if they can do these more effectively as if they can do them as outpatients. But typically the 4-1BB products, because of their better toxicity profile, at least up front, are better. It can be tolerated as an outpatient better. CR rates are relatively the same across the board, and toxicity rates, as you see here, there might be a higher toxicity rate of CRS and ICANS with these CD28 products, as you see. So I will just briefly mention that CAR T cells are moving into second line for DLBCL. This is as of ASH 2021, where there were 3 trials that were presented: the ZUMA-7, the Transform, and Belinda study. This is the ZUMA-7 study showing a definite benefit in the progression-free survival of axicil compared to transplant in second-line therapy for diffuse large B-cell lymphoma. However, no overall survival benefit as of yet, but this is probably because a lot of these patients then went on to receive axicil if they were starting to fail transplant route. But really stay tuned as to what will happen with this in terms of approvals. You can see also those other studies, but I just wanted to briefly mention this. For multiple myeloma, there are BCMA CAR T cells that are out there for triple refractory or triple exposed, so proteasome inhibitor, IMiD, and monoclonal antibody exposed patients. And overall response is relatively good. This is with the Abecma or idacaptogen cytolucil product. And you can see here, though, however, although the overall response is quite good, the progression-free survival wasn't exactly robust, and there wasn't a plateau in the survival curve, as you might expect with multiple myeloma. And so what happened is that this led to FDA and Health Canada approval. However, it led to a negative review at this current stage, at least for funding in Canada currently, as you can see from this CADIF recommendation. And the reason for this is this wasn't really phase 3 data to really confirm an improved survival. So stay tuned as to what will happen with BCMA CAR T cells in multiple myeloma. I think this will eventually come to Canada in some shape or form, just not quite at this stage. So moving on to CAR T cell toxicities and side effects. Well, probably the most commonly talked about one is something called cytokine release syndrome, or CRS, which is due to super physiologic activation and dysregulated immune activation within the first 2 weeks to 4 weeks or so after CAR T cell therapy. It's characterized by high fevers, as you can see here in these patients in red who had high-grade CRS, as well as endothelial activation, leading to hypotension, increased CRP, and ferritin. Early onset after CRS is a poor sign. So you see in this study that we published when I was at Fred Hutchinson that these patients with very severe CRS really develop their fever pretty much soon after infusion. Treatment is with tocilizumab, which is an anti-IL-6 receptor antibody, as well as high-dose steroids if needed. And early recognition and management is key of this. So I've provided for you here the ASBMT consensus grading system. And you can see it's based upon fever, hypotension, and hypoxia. And you have to have fever to have CRS. And then vasopressor support or not defines grade 2 versus grade 3. Hypotension and hypoxia, you see, it depends upon how much oxygen requirements they have. ICANS, or immune effector cell-associated neurotoxicity syndrome, also known as just neurotoxicity, really can be almost any neurologic symptom after CAR T cells. You see in the table 3 that I presented there, the commonly seen adverse reported events following these CAR T cell products at that point in time. So it can include things such as seizures, coma, and CNS bleeding. But really the earliest manifestations are tremor, dysgraphia, and aphasia. Treatment is with high-dose steroids, and we don't typically give tocilizumab unless there's concurrent CRS. And the potential reason for this is that the IL-6 is crossing the blood-brain barrier, but the anti-IL-6 receptor antibody is not. So it's really blocking things systemically, but not blocking things in the CNS. And so you could have a theoretical worsening of ICANS if you're giving TOCI at the same time. However, if they have concurrent CRS, definitely give the TOCI because you really need to get that CRS under control. Here's the ASBMT consensus grading system for ICANS, as well as the ICE score, which is a quick way of evaluating your patients. And I'd encourage you, if you're ever evaluating CAR T cell patients, to use this on a daily basis while you're following them on the ward, so that you can really get a sense of their trajectory. In terms of toxicity management, well, I just want to say there's an app for that. There is this app called CARTOX. You can easily get it on your phone, and it's a great resource to have to help you with going through the whole diagnosis, grading, and providing some recommendations on toxicity management. But the first thing is to really administer CAR-T in a facility that really with staff trained in CAR-T management. Then establish the temporal relationship to CAR-T. So as I said, it's most common within the first 2 weeks after CAR-T, and it's extremely rare after day 28. So that's why we tend to follow patients up until about day 28. The CRS often precedes ICANS and can even resolve prior to the ICANS. So if somebody starts to develop the neurotoxicity after their CRS is resolved, that is actually a common thing to occur. Use that ICE score, as I mentioned. Physical exam findings is what really drives this too. So fevers, hypotension and hypoxia. So really following their vitals. Cover for sepsis, febrile neutropenia, and evaluate for other reasons for their neurological change, including, getting neurologic opinion as needed. Grade the toxicity, as I mentioned, because specific interventions as to how much TOSA to use, when to pull out steroids, and what dose of steroids to use is a bit dependent upon the grade of toxicity being seen. Now, it's important to keep in mind that about 95% of this acute toxicity is reversible with no evidence of significant longer-term sequelae that we know of. So you can reassure your patients and your family, the family members of patients who are undergoing this therapy that even if they have significantly concerning neurologic symptoms, that if it's due to the CAR-T cells, those likely will resolve. So let's talk about some of those longer-term side effects. Well, one of the main ones is cytopenias. So cytopenias are very common after CAR-T cells. The causes, we think it's due to, first of all, we treat very heavily pre-treated patients with CAR-T. So these patients already have a beat-up marrow going into CAR-T. There has been some association fairly clearly linked to higher grades of CRS. So those who have, grade 4 CRS, for example, have longer and more persistent cytopenias, as well as there's a thought that maybe ongoing CAR-T cell low-grade activity in the marrow is actually what's leading to some suppression of the blood counts. And it might be that they're really killing off new CD19 positive cells, for example, that are just starting to arise in the marrow, and some of that inflammatory milieu might be causing suppression of the bone marrow. So what do we do with these? Well, we first of all watch and wait. The majority of these patients will eventually recover, as you can see from these kinetics here. You can see also that it tends to have this sort of biphasic pattern, commonly with the ANC as well. So they'll have an initial large drop due to the lymphodepleting chemotherapy, they'll recover, and then it's usually around, week 4 or 5 afterwards that they dip down again, and really they have a period of time of neutropenia and then eventually recover. So really just watch and wait initially. Obviously provide them supportive care as necessary, like transfusions and GCSF. And in cases of protracted cytopenias, so things that are happening for longer than 6 months, do consider at that point in time maybe doing a bone marrow to evaluate for something like myelodysplastic syndrome, because as previously mentioned, these are heavily pretreated patients who have seen a lot of chemotherapy already. So myelodysplastic syndrome is not unheard of to occur in some of these patients. Another major one to keep in mind is infections. So I typically, divide infections, just like Joshua Hill's article here that was published in Blood as a How I Treat, into 3 stages. So there's the acute toxicities, delayed, and late phase. So during the acute, we tend to worry mostly about bacterial, although there can be some viral activation, and Candida species are of a big concern during those first 28 days. But really, when we talk about the more delayed phase, we're worried about pneumocystis gyrovecii pneumonia, as well as HSV or VZV reactivations occurring. So these are things of concern, which is why we recommend valacyclovir prophylaxis up until at least day 28, as well as septic prophylaxis, usually up until about 6 months. And depending upon how we're doing the CAR-T cells and their infectious risks, if they're having cytopenias, if we send them out of hospital, often we'll suggest some sort of antibiotic and antifungal coverage during that point in time. Now, IVIG administration is a little bit controversial in terms of what is actually needed, but here's a good guide is really if it's below 400, really consider replacement, especially if I would say if they have any serious infections or recurrent infections. If it's above 400 and there's no signs of infections, really this isn't as much of a concern. Revaccination is commonly done at 6 months following CAR T-cell therapy, starting that revaccination series of similar to the vaccines that somebody got in childhood. Every site, though, however, might do it slightly differently, so really check your site's policy as to what is being done. The thought here is that because of all the immunosuppression that's happened is that some of the immunity has waned, although I think more data needs to be gathered on this. So let's talk at the end here now about what is the future of CAR T. Well, the CAR T immune cell therapy landscape is complex. So I looked today on clinicaltrials.gov, and if I focus just on the actively recruiting studies, there are 535 CAR T-cell studies actively recruiting as of right now. And you can see here all these different companies that are involved and have a stake in this game of moving things from preclinical testing all the way to the market. So we have this huge range of CAR T-cell products that is really coming to the market, and not just CAR T, CAR NK, TIL products, TCR receptor-based products, allogeneic CAR T cells, etc. So this field is rapidly expanding. So what I may be seeing today may change in a couple years very quickly. So some of the thoughts as to how we can improve CAR T and make it more effective are as follows. So first of all, if you look at A here, we really need to overcome antigen escape. And so because CD19, for example, can be lost by some of these tumor cells. And so one thought is to make dual CAR T cells or tandem CAR T cells, for example, or throw in a mixture of CAR T cells. Another idea is to make a CAR T cell that then secretes a BiTE and activates a different antigen, or we potentially infuse something where the CAR itself is common, but then we infuse various different antibodies that could target various different tumor-associated antigens. Another thing is that these CAR T cells are lost after a period of time in the body. So as I mentioned earlier on, we're hoping for some degree of persistence to act as sort of, so to speak, a whack-a-mole to prevent the cancer or leukemia from coming back again. But occasionally these so we're really trying to understand the biology of these CAR T cells and how these T cells just die out, and we're trying to understand how we can make them stay around for support using different T cell subsets, etc. Next thing is to really increase tumor homing and penetration, especially if we end up going into solid tumors, because the tumor microenvironment is a really immunosuppressive environment, and that leads us into panel D here, where we talk about various different modifications that could be done. So, for example, knocking out the PD-1 gene in the T cells, in the CAR T cells, so that they can't get blocked that way. Or having a CAR T cell that secretes an anti-PD-1 antibody, as some just simple examples. Or you armor the CAR so that it secretes a certain cytokine that helps activate the rest of the immune system in that microenvironment and makes it more tumor killing as opposed to tumor supportive. A big challenge for the field, as you may have gathered from what I just stated, was really how to make these immune cells work in solid tumors. And one of the reasons I point this out is because us as typically, most people who do CAR T-cell therapy currently are hematologists. But if you look at, cancer statistics in Canada, really, leukemia and myeloma lymphomas make up a smaller percentage compared to things like prostate, lung, colorectal, and breast cancer. So really, once effective CAR T cells are made for these solid tumors, this will really blow all of our activity out of the water in terms of what we're doing for CAR T cells in hematologic malignancies. Which leads me to this point. CAR T cells are not without their cost. The public list price of Tisa-cel for B-cell ALL is close to $500,000 US dollars. The public list price of Axi-cel and Tisa-cel for diffuse large B-cell lymphoma is slightly less. Now, we don't know the exact prices in Canada because these Canada-wide price negotiations were confidential. But if you look at a cost effectiveness of Tisa-cel and B-cell ALL from the one study that showed that it was in this range, so up to 213,000 per quality adjusted life year, and of both products in DLBCL of up to 223,000 US dollar per quality adjusted life year. This is actually quite high, and if we assume what's a commonly assumed willingness to pay threshold, so that's WTP, willingness to pay threshold of somewhere between 50,000 to 150,000 US dollars per quality life, you can see that these costs are really on the upper end. And so although our healthcare system may be able to do this while the indications are rather minimal, while we're using this only in the relapse refractory setting, if we really are moving these further, earlier on in the therapy cost, if we are expanding indications to other cancers, costs will need to decrease if these indications increase in order for this to be a sustainable thing for our healthcare system in Canada. So what is the cellular immunotherapy need in Canada right now? Well, patients, they need access to high quality standard of care and innovative treatments. What does our healthcare system need? Well, it needs financial stability and sustainability, as well as secure supply chains for biomanufacturing, as we have learned from this whole COVID-19 pandemic. Clinicians and researchers really want high quality treatment for patients, and we also want to actively contribute to this burgeoning sector of healthcare and to recruit and retain talented experts here in Canada. So really, we need to figure out how to make these cell therapies work in Canada. So in conclusion, CAR T is a genetically modified cell therapy with BCMA and CD19 as being the targeted products that have demonstrated the most success so far. The main acute toxicities of CAR T cells are CRS and ICANS, which are managed with cytokine blockade or tocilizumab and steroids. Longer-term side effects include persistent cytopenias as well as increased risk of infections. Finally, looking forward to the future of CAR T cells, targeting solid tumors, preventing antigen-negative escape, and dealing with the financial toxicity of CAR T are some of the significant challenges in the field. Thank you very much for listening to my presentation.